Now, there have been a number of studies done in Europe and in Asia using ultrasound contrast looking for liver metastases. This is a study in which I took part looking at the first generation agent and comparing with spiral CT. And what this study shows is that the pulse inversion contrast imaging at ultrasound is significantly better than conventional ultrasound, showing many, many more lesions, and is also capable of performing almost identically to what was then state-of-the-art CT imaging. Obviously, CT imaging has improved since then, but so has the ultrasound contrast imaging. So as is typical in radiology, all our imaging techniques improve in concert and remain equally competitive at all times. And there are many studies that have confirmed this. Contrast ultrasound is at least as good as CT scanning and is probably nearly as good as MR scanning in the liver. Now, one of the important areas in the liver that we need to establish, particularly in patients with colorectal cancer liver metastases, is the presence of very small lesions or satellite lesions. And this is what I mean by a satellite lesion. Here is a large colorectal cancer which has been surgically excised, and here you can see a sub-centimeter lesion. It is about 1 to 2 centimeters away from the main tumor mass. And colorectal cancer metastases spread through the liver largely by invasion of the vascular spaces and can grow along blood vessels and appear as separate metastases within this halo of 2 or 3 centimeters around the main mass. This has always been the reasoning behind the surgical dictum that if you excise a colorectal cancer metastasis, you must take at least a centimeter of normal tissue as a safety margin so that you gather in these often microscopic satellite tumors. And we know that CT and MRI are not very good at picking up sub-centimeter lesions because the inherent contrast is insufficiently great. Here we can see in the same patient a satellite metastasis, again well under a centimeter. This is about 5 millimeters in diameter. We can see again it's about a centimeter away from the primary tumor, and we can see exactly where this is in relation to the primary tumor. So it's obviously important to remove or ablate this lesion as well as the primary tumor mass. Here's a second distant metastasis. Again, you can see the very high contrast that we have in contrast ultrasound between the poorly enhancing tumor and the surrounding normal liver. So we can be quite confident in diagnosis of lesions down to about 5 millimeters in diameter. There are various different modes for displaying the ultrasound contrast result. Here's another metastasis, about 2 centimeters in diameter. Again, note the very high contrast ratio between the tumor and the surrounding enhancing normal liver. This also applies to looking at the periphery of individual tumors. And one of the features we've noticed with colorectal cancer metastases with CT is that we often have arterial phase enhancement on the periphery of the lesion rather than the center. And we can see this pattern of these separate tumor nodules growing out or budding out from the main tumor mass very clearly with contrast ultrasound. And this type of pattern has been associated with a poor prognosis. If you look at the basic B-mode image, those of you who are experienced in ultrasound will recognize that there's obviously an abnormality there, but the clarity of definition of that mass is dramatically better with the contrast ultrasound. Here's another example of a paper published in 2003, where we can see contrast in ultrasound shows more metastases than CT, and in patients who've had other standard reference imaging techniques such as MRI, intraoperative ultrasound, or examination of implanted livers, CT does not perform as well as ultrasound. And there are many papers to confirm this now. So contrast ultrasound in detecting metastases is as good as MRI. It's better than CT scanning. Another example showing demonstration of sub-centimeter lesions in relation to a large metastasis with an enhancing rim. Very clear definition, very important for surgical planning. So that's detection. It works. Characterization of liver lesions. Well, the principles on which we work are very similar to those of contrast studies at CT and MRI. This is a study again from 2002 using the high mechanical index technique, which was all we had in those days, trying to compare the properties of benign and malignant lesions, and we can see that homogeneity on the late phase is typically benign, no late phase enhancement is typically malignant, and so on. Here are some examples. Again, an obvious metastasis, very clearly seen. Here's a tiny metastasis seen on the periphery of the liver, which is less well defined as CT equivalent. Lesions such as focal nodular hyperplasia do show characteristic features, and typically they will show strong lesion uptake of contrast and late phase imaging, which we don't see in the typical malignant lesions. And in many cases it's possible to see the scar, the central scar of focal nodular hyperplasia, which the pathologists tell us is always present, but it may be no more than 1 millimeter or so in thickness. So here's an example of focal nodular hyperplasia, not much to see on the conventional ultrasound image. Here's the central scar visualized in the arterial phase of this FNH. If you see the central scar, you can be very confident in your diagnosis. The temporal enhancement pattern also lends to significant confidence. Being able to characterize hemangiomas at the time of the original ultrasound scan is important and can save considerable costs. Typically we will see characteristic globular enhancement on the periphery in the arterial phase, and this is particularly true when we're dealing with larger lesions, which we are much more likely to classify as atypical from their morphological characteristics. Small lesions we can usually characterize very well just on their morphology. It's the atypical lesions that are more difficult. Here's an example. Here's a 5 centimeter diameter hemangioma. Its characteristics are not typical morphologically, it's not particularly echogenic or well defined. Here, after administration of contrast, we can see the absolutely classical nodular peripheral enhancement that we're used to seeing at CT. We can say with great confidence that this is a hemangioma and requires no further attention. The low mechanical index technique gives us a much greater opportunity to study blood flow during the different phases. In fact, we can scan continuously for several minutes through the volume of a tumour, and hence we're not looking at phases but a complete dynamic examination. So the other factor that's important with the low MI technique, if you go back to one of my original slides, the tissue harmonics that are generated by the passage of an ultrasound pulse through the tissue are reduced at low power. They're really a function of high power imaging. So we still retain the bubble harmonics, however, so we get a better signal to noise ratio at low power than high power, which is completely unlike CT or even MRI. So at low MI imaging, the initial phases emulate dynamic CT. We're looking at arterial and portal venous imaging, but the late phases, the bubbles are retained in the microvasculature, and this is closer to the kind of reticular endothelial imaging we will do in the liver using specific ultrasound, MRI contrast agents such as SPEO. And the agent that is licensed in Europe for this type of imaging currently is the agent Sonoview, which is the most widely used agent in Europe at the present time. And we use this almost exclusively in this low mechanical index imaging mode. Here's an example in the early vascular phase. We can see we're visualizing the individual large vessels particularly well, showing no enhancement in this malignant tumor. Here's another example of later phase imaging where we can see again the microvasculature of the tissues with very poor microvascular filling in the tumor itself. Because the technique is very sensitive to very small lesions, here's an example of a patient planned for surgery for resection of metastases, and we can see in this CT scan multiple enhancing lesions down to a few millimeters in diameter. Now, this is an exceptional CT scan. We will only get this kind of image quality possibly only for a few seconds during one part of the arterial phase. And in CT now we divide it up into early and late arterial phases, but we can never predict exactly which point in time will give us the best image. With the ultrasound contrast we can detect these lesions equally well, but by continuous scanning we're less temporally rigid than we are with CT.